Our next presentation is from the group at University of Colorado. It is Novel Electronic Health Records-Based Consultation Workflow, Improves Time to Operating Room for Vascular Surgery Patients in an Acute Setting, presented by John Igwidbashian, Michael Schaefer, Kyle Bata, and Jenny Ann Yi is the senior author. I apologize if I mispronounced.
Oh, excellent. Good afternoon, and thank you for the opportunity to present. We have no disclosures. So traditional consultation workflows can be inefficient and prone to errors in communication. This leads to delays in care, poor resource allocation, and worse patient outcomes. We believe that recent advances in technology have improved electronic health record systems, which can streamline care coordination and is an increasingly incentivized method for improving care value. This is particularly important in time-sensitive services like surgery. I would say vascular surgery is especially vulnerable to delays in care given the acuity of the presentation, with a recent paper showing that an estimated 54% of inpatient operations that are classified as urgent or emergent in nature. I think we're all familiar with the challenges and pitfalls of inpatient consult workflows. We evaluated this problem at our institution and found several key factors leading to the inefficiencies. For one, there's minimal to moderate utilization of the consult order in general, leading to a culture of viewing the order as not mandatory. Communication loops are not always closed between providers, and then there's the dreaded curbside consults where you provide verbal recommendations with nothing formally documented. Unfortunately, without a consult order, the billing is also not automatically linked to the consult documentation. We quantified this problem at our institution and found that there's between 8,000 and 12,000 consults per month. However, only 14% of consult orders were completed accurately and completely within 24 hours of the initial order. Additionally, 53% of the consult notes that were documented in the chart were linked with a formal consult order. We obviously needed a change at our institution, and we proposed that with an improved and modified consult workflow, we could reduce patient harm, improve patient satisfaction, and be more compliant with the Joint Commission's mandate on consult orders. Our solution to this problem was to implement a novel, automated, and standardized EHR-driven consultation workflow. This is a sample of the order, which includes the reason for consult, priority status of the consult, and preferred callback method. After the consult is placed by the ordering provider, it is automatically sent via pager or Epic Secure Chat messaging to the consulting service. The patient is also automatically added to the consulting service patient list and will remain on the list until the consult is completed. In addition to or as part of the order, there's also clear instructions to complete the actionable recommendations in the Epic chart within 24 hours. We hypothesized that the implementation of this novel EHR-driven consultation workflow would improve the timeliness of care for our vascular surgery patients. We compared a pre-implementation cohort to a post-implementation cohort with the primary outcomes of time from the consult order to note creation with recommendations, and also time from the consult order to time to the operating room, or to the operating room. In total, we had a total of 255 vascular surgery consults prior to the implementation of the workflow, and 299 that fit criteria in the post-implementation group. There were no significant differences in the patient characteristics for these cohorts. We also documented the role of the ordering provider and found that approximately 50% of orders were initiated by residents, with 25% from an attending and 25% from either an NP or PA. Again, these were no different between cohorts. We then stratified our consultation orders based on those who needed an operation resulting from the consult, which resulted in 45 patients requiring surgery in the pre-implementation group and 76 in the post-implementation group. Again, there was no difference in characteristics including age, gender, common comorbidities, and ASA status. First, we looked at time from consult order to note creation with recommendations. We found that overall there was a 32-minute decrease in note creation in the post-implementation group. We also saw decreases in all categories, including age, role of the consult orderer, and case status. However, these did not reach significance. We next looked at time from the consult order to time to the operating room. Again, we saw decreases in all categories, including age, ASA status, role of the ordering provider, and case status. However, these also did not reach significance. Next, we looked at a multivariate analysis and found that if the order was initiated by an attending, it was determined to be urgent or emergent with a high ASA status. The time to the operating room was decreased by a significant 104 minutes. Here you can see the trend for urgent and emergent cases after implementation with a clear trend towards decreasing time to the operating room. We found that our novel EHR-based automated and standardized consultation workflow significantly improved timeliness of care for vascular surgery patients at our institution. ASA class, ordering provider role, and case priority impacted decreased time to note creation by approximately 8% and time to the operating room by up to 36%. Age, gender, BMI, and common comorbidities did not significantly affect timeliness of care. We believe that standardized and automated processes represent powerful tools to increase the value of care in vascular surgery practices. Going forward, we plan to further refine and provide education at our institution to further improve the efficiency in this platform. We're evaluating clinical outcomes, including length of stay, surgical site infection, overall complication rates, and 30-day morbidity and mortality. We're also working on disseminating this workflow across the other hospitals in our state or in our statewide network, but we believe this has potential to be expanded at institutions with compatible EHRs. Thank you.
Dr. Sheehan.
Malshayan, LSU. I suspect all these people are not jumping up to congratulate you on this.
Wow.
It sounds like you had a god-awful system and you made it merely terrible. So, now they're all going to sit down because that's what they were going to say. Why? Just why do we have to do this to ourselves? If you put something in my Epic inbox, I'm going to die of old age before that patient dies. Like this is not what we need to be doing. And this is not a criticism of you. This is a criticism of our system and where we find ourselves. I'm not criticizing you at all. Your hospital, maybe, but not you. But yeah, we have Epic, and yeah, we have to somehow exist within that machine. But this takes away how we've always gotten consults done, right? We've always called and talked directly doctor to doctor about these things, even on a resident level. So I'm sorry this isn't a question, but I just implore you. Misty has a question, surprisingly. But I just implore you to kind of look at this again.
So his question was, so you talked about how if an attending, put in the order, why not just have the consults be called by attending when you have somebody really sick? So that's his question. So why do we have to put something into Epic? Do we just need to use the buttons on the phone that dial the number, not just the letters on the phone? And wouldn't that be just as good to close the loop on communication?
Yeah, good question. So we really were finding miscommunications in the process of searching for the correct pager in our call system and having delays of care, mostly because it was going through interns that were overlooked or overworked. So we found those frustrations more challenging than an automated system where the consult was more
Let me
easily
defend you a
reached.
little bit here.
Right.
Here's the problem. Are you going to mandate that attendings call other attendings for a consult?
We do, yes.
Okay, so you're scrubbed in. Okay, so then what happens? No, but you're scrubbed in. They're calling you for a consult, and you're scrubbed in a 6-hour case. So what happens?
Yeah.
So that, so the problem is the onus falls to the attending, number one. Number two, there's no
I
documentation.
think it's actually, sorry,
Right.
can I just?
Yeah.
I think it was actually a surrogate marker for urgency, because what this process was is you didn't have to pick up a phone and page anybody anymore. You just placed an order and a page would go out. Or if you choose to do unified communications on your Epic app, that's how you get notified. So, but I think that an attending placing it also is a surrogate marker for urgency because it also only went up for urgent cases and for sicker patients. I understand the sentiment of what's being expressed, and that's part of why we tried to refine this process is because it was so cumbersome to get somebody on the phone to actually talk to you. And I think what this showed is that we could get someone on the phone talking to us faster and get this patient to the OR sooner. But maybe I'm an optimist, I don't know.
Jim.
I do have a couple more questions following up from Mel in representing the seniors group. But, you know, my Epic chat is inundated with dietary change, urgent dietary changes, dressing changes, issues, and everything else. So, I mean, I could literally sit at my computer and just all I do is Epic chat and this type of thing. So I don't know if this gives us a sense of priority. The question I have is, and I may have missed it in your presentation, but you said quickly, what were the cases? I mean, are we talking about people with ischemic legs? Are we talking about, oh, I need an IV filter put in, or I need a dialysis access in a more timely fashion? So, you know, and we had a little sidebar, you know, a lot of this is they're trying to get, the hospital's trying to do more and more of the work. We have a consult resident. I mean, this is the old academic, but we have a consult resident. They know who it is. They go in, and with Amnion, they can say, who's the consult resident? The resident is not in the OR, so they'll come to the OR and say, we've got somebody with a cold leg, or we got somebody that needs an AV fistula, and then we'll prioritize it based on that. Now, we may not get a note in Epic in the time, but we will prioritize it based on that. So I guess, you know, you say, oh, quicker the OR, but for what? Is this a symptomatic aneurysm? Well, that's a problem, and it goes back to your system of how you communicate. But if it's for, you know, a dialysis access, declot or whatever, it may not have that same sense of priority as a cold leg.
Yeah. So what are your cases? Yeah. I guess 2 comments. One for the Epic dislikers. The consulting service can request or prefer one pager or Epic secure chat. So it's not always more secure chats. And then to your point, I didn't include it, but we almost immediately excluded cases that were over 24 hours or requested for over 24 hours. So those are the IVC filters and things like that. And then I think another... What were your cases? What were your cases? Well, they were all... The acute limb ischemias, all cases were included in the study.
So it was very helpful to see a plot of, we had these consults that got to the OR quicker, and they were 10% were acute limb ischemia, 3 were whatever, just have some idea, because again, I could get an Epic chat on Friday afternoon and I say, okay, we need to come in, the guy's not setting your nail, but I'd like to breathe foot tomorrow. And they'll say, no, we got hip or integrating bleed. And so I say, do it on Monday in your block time and help yourself.
Yeah.
So I guess I need to appreciate what you've done and get a better idea of what was being missed and how we were able to expedite and did it.
Yeah.
Don.
Yeah, Dawn Coleman at Duke. First of all, that's a really tough concept that you've just presented to the team. This is lots of energy, some of it really negative around the EMR. So bravo for being brave and standing up and doing this. And I credit your mentor for her toxic optimism, which resonates with me. And really an effort to fix a system that clearly was not working at your institution. And that's who we are. We're problem solvers as vascular surgeons. I will say just a couple comments and one question. Having just transitioned from one major academic center to another, everybody is going to find a different system that works for them. And so we all have to do that. A word of guidance for the faculty who hate the EMR, and I hate it. I hate it so much. You can make yourself unavailable for 999 years And I've done that, and nobody will bother you through the Epic chat. And turns out it doesn't actually compromise patient care. What you've done, though, is highlighted a problem in capturing work, and that matters because your work should be valued. And so you may want to think about how you spin your messaging in your manuscript, because you've recognized space of lost revenue that shouldn't be lost, and now you've captured it. So that's one thing that you've done really nicely with this work. For the trainees, though, in the room, Dr. Humphrey's concept and point about picking up a phone and hitting buttons really does matter. And so there are ways to level out urgencies for acute care needs that should supersede attendings making phone calls. And there are ways to do that, and there are practices at institutions that work really effectively. So my singular question for you, as you move forward at your home institution, what's the big takeaway that you think will actually make a big difference in patient care? Thank you.
Yeah, I would say it's understanding how to triage patients, because a lot of the urgency status is one, how you place the consult order, but also how you request the case. So I think understanding how to triage the patients, obviously go up the chain for senior residents and attendings.
So I just have a couple comments that might link some of the comments that have been made together. First of all, I tend to agree with much of the group in this room that maybe this is not the right thing for all vascular consults. Some consults are different than others. That said, I will also say that the functionality of Epic has found ways to make our lives so much worse in so many ways that it makes sense for us to take some control of those mechanisms ourselves to streamline some of the work that we're already doing. So for that reason, I think this is actually a great endeavor, even if the first attempt at this kind of misses the mark. At my institution, we do a similar thing using an urgent Epic chat function specifically for dialysis access problems, to Dr. McKenzie's point. And that has worked extremely well at dealing with some of the miscommunications between nephrologists and residents. Residents and fellows are not going to prioritize a perm cath, but the nephrologists want that done. So if we have an Epic chat that funnels all that kind of crap right to one point of focus that one of our administrators mans rather than physicians manning, and sort of puts that into the work queue, it's actually helped us quite a bit. It's helped our nephrologists, it's helped us sort of get these cases on the board. So I would encourage you to keep going with this type of work in a way that maybe is a little more tailored and makes more sense than a general vascular consult.
Okay, we're going to move on, if that's okay. I will say this before we move on, though. My 17-year-old son in high school just texted that he's with Colorado, the future is now old man, quote unquote. So there you go. That's how the youth see it.
Thank you.